Hello, and welcome to another episode of MCREG International on the Go. I'm pleased to be joined by Dr. Gregory Furman. We're talking today about what specifically we have as far as severe bleeding in the ED or in the ICU. So if you could say what constitutes severe bleeding as an emergency physician, as a practicing emergency physician, what does that mean to you?
So for the definition of severe bleeding, Brian, we turn to the International Society of Thrombosis and Hemostasis, otherwise known as the ISTH. And the ISTH defines major bleeding relatively well, not only for research purposes, but also for clinical purposes. And it first is a major bleed. A major bleed is a fatal bleed, obviously, or a bleed in a critical organ. So a critical organ is defined, not surprisingly, as an intracranial bleed, as well as an intraocular bleed, something happening in the eye, the retina particularly. Also, pericardial bleeding, retroperitoneal bleeding, and some large joint bleeding also defines a critical organ. Now, in addition to the critical organ location, any bleed that causes you to drop your hemoglobin by more than 2 grams or requires 2 units of Pactel transfusion also defines a major bleed as well, such that, for instance, in a non-critical organ like a GI bleed or something like that, you can meet the criteria of major bleeding if you meet the criteria of losing 2 grams or having to be transfused 2 units of Pac cells. Now, they also define clinically relevant non-major bleeding, which is a mouthful, but also defines those sites such as mucosal sites like nosebleed or GI bleeding or something like that that might actually be clinically meaningful but doesn't meet the criteria for major bleeding. Procedurally or paraprocedural bleeding, such as post-biopsy bleeding or post-tooth extraction bleeding, is another bleeding site that we often are confronted with having to manage in the emergency department. In addition, muscular bleeding and wound bleeding, such you might see in post-trauma, is also something that we need to manage.
As you brought up, Greg, this is important for emergency physicians because more of our patients are coming in and they're anticoagulated for underlying disease processes like DVT, PE, or atrial fibrillation. And now all of a sudden you've got that patient before you and you've got bleeding. You have to determine whether it is significant or insignificant, and having the backdrop, if you will, the understanding of what constitutes a significant bleed. I think it's pretty obvious if somebody's bleeding into their head, might not be so obvious if they're bleeding into their eye. And so I wanted to get your thoughts on that as far as for emergency physicians. Are you seeing that as being a significant issue for them?
Sure. So as emergency physicians, what we do is try to deploy certainly our history and physical exam. And so this slide that you're seeing now nicely depicts those signs and symptoms that you might see with hemorrhage into the organs that we just talked about. But we're also going to deploy advanced diagnostics like CT and the like to help us diagnose, for instance, a retroperitoneal hematoma that may not have physical findings that are readily apparent. Likewise, we can use MRI and other diagnostics to help us diagnose these things.
Well, Greg, thank you very much. That provides great clarity to this topic. Thank you very much for watching MCREG International on the Go.